Good afternoon. Welcome to Health Talks, a production of Arizona State University's College of Health Solutions. My name is Marcus Jones, and I will be serving as your moderator for today's talk. This afternoon, we will be discussing COVID-19 and its effect on vulnerable populations, today specifically older adults. Today, we have two great presenters, the first being Dr. Mindy Fain, Professor of Medicine at the University of Arizona's College of Medicine and Chief in the Division of Geriatrics Internal Medicine and Palliative Medicine. Following Dr. Fain, we will also be joined by Dr. Greg Meyer, a professor of practice at the College of Health Solutions and former medical director for the Hospice of the Valley. Dr. Fain, we'll let you take it away.
Great. Well, good afternoon, everyone. I'm looking forward to today's discussion and hearing your thoughts and questions that you might have. As you've heard, this session will explore the many ways that COVID-19 has impacted older adults. And we're going to talk about why that might be so and what can be done to support older adults during this crisis. So to start, just to get our terms right, because I was a little confused in the beginning, COVID-19 is the name of the disease that's caused by the novel coronavirus, SARS-CoV-2, or severe acute respiratory syndrome, coronavirus CoV-2. We thought we knew this, the family of coronaviruses pretty well. These viruses have been around for a long time. They're well known for the common cold. About 4 of them are responsible for about 30% of our colds. And it's the agent of SARS-1 and some other conditions that you may have heard over the years. Unfortunately, this novel coronavirus has emerged as exceptionally hardy, exceptionally contagious, with very high morbidity and mortality. And the brunt of the pathology is shouldered by older adults. If you could go to the next slide. Thank you. So older adults are at high risk, especially those with multiple chronic conditions and disabilities. So let's just talk quickly and look at the numbers a little bit. In the US, 80% of all deaths have occurred in people over the age of 65, and that mirrors the experience in the rest of the world. Those over age 85 suffer most of the severe outcomes. And then there's a thing called the case fatality rate, which is the ratio between confirmed deaths and confirmed cases that you may have heard of. It's extraordinarily high in older adults. Just to give you an idea, those 70 to 80-year-olds have a case fatality rate of 8%, which is quite high. Those above age 80 have a case fatality rate double that of nearly 15%. And as we've heard and we'll hear more, there's rampant spread of COVID-19 among nursing home residents and workers. And the numbers are pretty astounding. About a third of all COVID deaths in the US can be traced back to nursing homes. And this translates to about 34,000 people who have died in long-term care facilities. It's important to add that minority groups of all ages are disproportionately affected by COVID. We expect that these health disparities and inequities would continue with older adults. The data is just coming in. We expect that it would be even more strongly a factor for older adults. Early data suggests that that's so. And so, Mark, next slide, if you would. There are lots of reasons why older adults are vulnerable to COVID-19, and the aging immune system is a good place to start to understand where we are today. So to start, a little background about the immune system. Our immune response is divided into 2 phases. One is called the innate phase, and the other is adaptive phase, or innate immunity, adaptive immunity. And these 2 phases both undergo significant changes with aging. The innate system is an older evolutionary defense. It's immediate, it's nonspecific. It's the first line. It can be thought of like a hammer. It involves physical barriers, chemical and cellular defenses against anything that tries to invade us. It involves chemokines, or what's called pro-inflammatory cytokines, but it doesn't involve antibodies. That's where the adaptive immune system comes in, or it's called acquired or specific immunity. That's the second line. Antigen-specific, really highly specialized line of defense. It takes longer for adaptive immunity to kick in, usually about 4 days or more, but it's the one that lasts for years and years. It involves T and B lymphocytes, you may have heard of them. It involves, importantly, the development of antibodies, more sophisticated, highly specific. A major problem is that older adults, you can be thought of getting stuck in the innate phase. And it's really problematic and trouble moving on to making protective antibodies. Well, while aging affects these two phases differently, individually, these two phases have to talk to each other and coordinate with each other, and that gets messed up with aging too. So the sum of these changes means that older adults are particularly vulnerable to new emerging infectious diseases that was seen with SARS-1, with the West Nile virus, and now COVID-19. And if that's not enough, there's more. So while the immune response is critical to resolve COVID-19, the immune response can also do harm. And it can be responsible for those poor outcomes in the second week of illness when you've heard suddenly people fail abruptly. And for some, that has to do with progression to what's called the acute respiratory distress syndrome, or ARDS, which is very serious and often terminal complication. And it's marked by what's called a cytokine storm, a cytochrome storm. And that's reflective of this disruption and inability to transfer to the best phase. So one could describe this unsuccessful immune response in COVID-19 to being stuck in innate immunity, whereas the progression to adaptive immunity with antibody production strongly correlates with favorable outcomes. And I mention this in some detail, which I hope is not too much detail, but as we look to vaccines and future vaccination strategies, they're going to need to elicit a strong protective antibody response in older adults in order to be successful. So next slide, if you would. So let's talk a little bit more about older adults and what makes them vulnerable in addition to the immune aging. Well, with aging comes other physiologic changes across multiple organ systems, which can be thought of as a limited reserve, a limited ability to bounce back or maintain balance or homeostasis. And it includes all of our body in different degrees. The entire body doesn't age exactly the same. Different organs within us age at different rates, but it includes lungs, heart, kidneys, muscle, bones, and all of this limited reserve, limited ability to bounce back brings additional risk. In addition, as we grow older, we all grow older, we accumulate chronic conditions. For people over the age of 65, 85% of us have one chronic condition. And for those and about 60% have two or more chronic conditions. And all of this, as you've heard in the news, makes us more susceptible to developing a severe infection. We've heard of the conditions like diabetes, heart disease, hypertension, obesity, chronic lung disease, all as being risk factors for poor outcomes. So to put it in perspective, how common are chronic conditions in older adults? 60% of older adults are hypertensive. 30% of older adults have diabetes. It just helps put it in perspective for us in terms of risk. There are other conditions that you may or not heard about. Frailty, or the frailty syndrome, is a very common age-related geriatric syndrome, which has a strong impact on COVID-19. About 30% of people over the age of 85 are frail. And then we think of cognitive impairment, dementia, or functional disability, people who need help with activities of daily living or they suffer from falls. These lead to additional challenges in different ways. For example, it complicates the ability to socially isolate, brings in the need to have supervision, people coming into your home or having to move to supervised settings, nursing homes, all of that adds risk. So on to the next slide. So keeping that all in mind, there are unique aspects of COVID-19 and how it transmits that contributes to the pandemic. And this unique transmission is one of the leading contributors. The virus, and we're all pretty knowledgeable about this, but it's worth mentioning, it spreads primarily by direct contact with respiratory droplets from person to person. There was a lot of concern in the beginning about contact by touching infected material and then touching the mouth. That's being looked at and is an evolving issue about how long these droplets stay active on other materials. Interestingly, the virus doesn't typically produce sneezing that produces the aerosol that we've all learned to be worried about. It doesn't do that, but it has other aspects that are very alarming, really. Very long incubation period, a range of from 27 days with a median of 5 to 6. About 100% of people who develop symptoms from COVID will do so within 11 or 12 days. So once you're out of that window, overwhelmingly you won't develop symptoms. But an estimated 50% or more of asymptomatic people who don't know that they're infected, will shed virus. And so this is really problematic for frail older adults who receive direct care and contact from people who may be asymptomatic and remain asymptomatic and never know they have the virus, or are pre-symptomatic in that prodromal stage. Anyway, they silently spread the virus, unintentionally across, really, for all of us, but especially in long-term facilities. And the next slide, if you would, and we can talk about clinical symptoms and signs. So clinically, the illness caused by SARS-CoV-2 can range from mild to critically ill to death. About 80% of patients report mild symptoms, but this is likely much more common in younger populations. And this population is really undercounted. They don't often seek help. They don't often get offered testing. Severe symptoms, shortness of breath, lung involvement, everything we've heard about, are reported overall in about 14% of people. 5% develop a critical illness. So if we look at the normal, usual person who develops illness, it includes fever, fatigue, dry cough. Less common symptoms: headache, problems with taste and smell, cough with or without sputum production, as we said, sore throat, chills, nausea, vomiting, some other GI symptoms. The virus has a predilection for the lower respiratory tract, resulting in pneumonia. Other symptoms that you've heard about include funny skin lesions, COVID toes, things like that. Stroke. It's good to know the common symptoms that occur among young and relatively healthy people. Older adults, and especially frail adults, often present atypically. And as a geriatric, we like to call it typically atypical, because for older adults, it's not atypical. It's only atypical compared to what we consider the normal person. But they have blunted fever, if any fever at all. They can present with confusion or delirium, unexplained low oxygen levels, which create other kinds of symptoms, rapid heart rate, rapid respiratory rate, falls. These atypical presentations, again, actually typical for older adults, confounds and delays the identification of the problem and management. For instance, for somebody who has lung disease or heart failure, shortness of breath can easily be misdiagnosed or misunderstood as just a worsening of their underlying condition. For all ages, the definitive diagnosis is the nasopharyngeal swab. For older adults, I want to mention that those who have any cognitive impairment, symptom assessment, even just getting a history, can be really challenging. So next slide. So it's a new, and effective management and treatment approaches are literally evolving every day. The most important strategy is primary prevention of the initial infection, halting spread of those who are infected. And as we know, all cases or suspected cases should be isolated until effective treatments or vaccines become available, and the main treatment is supportive. Management starts with diagnosing and triaging the older adult to the appropriate level of care. We hope that most cases can be managed at home, but higher levels of care may be required. The goals are to avoid exposing the patient to unnecessary risk and avoiding overwhelming the healthcare system, but making sure that the person is at the correct level of care. There are multiple trade-offs: coming to the ED, hospitalization, returning home, returning to a senior care facility. As early as possible, way before any of this, really, advanced care plans should be reviewed and discussed, and especially within the context of COVID-19. You know, educate patient and family regarding the disease course, what may happen with an ICU admission, the risk of mortality, how it impacts on quality of life, the disease and late effects, and as in all care, treatment plan should align with patients' goals of care. I want to, next slide if you would, because for those of us, there have been, in addition to the high morbidity and mortality burden that COVID-19 has brought upon our older community, it's also opened up for us really what could be called the chronic wound of ageism. It really laid it bare. Ageism is a funny ism. It can be thought of as a prejudice against our future selves. I did not make that up. I can't remember quite who said that first. With COVID-19, ageism has taken many forms, many of them very public. And I'd like to go through them one by one. And the first is that we are now engaged and have been engaged and likely will be engaged in a public discussion of allocation of scarce resources. And there are some people who propose the use of age as a means for excluding one from treatment. And many of these suggested approaches are disturbing. I put in a reference at the end for the American Geriatric Society position statement about resource allocation strategies and age-related considerations in the COVID-19 era and beyond. And it really looks at a distributive justice that maximizes relevant clinical factors, de-emphasizes arbitrary or disproportionate weight on advanced age. And again, refer you to that paper. We're also hearing disturbing public statements expressing relief that only old people are dying of COVID-19. Could you imagine someone expressing relief that only children are dying of COVID-19 or only young people are dying of COVID-19? But we hear this said. Older people are also in some way being blamed for the economic collapse. And there's open discussion of the idea that we're all forfeiting our economy and our futures for the sake of protecting these old people. And it has been, public conversation that maybe old people should volunteer to be expendable and offer up for the sake of society. A few other things: older people are suddenly and unexpectedly dependent upon others, which is really devastating. This sudden withdrawal of home supports, such as home delivered meals, senior centers, visiting nurse, family, rapidly exposed many older people who are, doing okay as being very dependent on others. And it also gave the impression to some that all older people are dependent and live in nursing homes. So I thought this is a time to just remind us all that only 5% of older adults live in nursing homes, 2% live in assisted living, 93% of older adults live in the community. Last, there's been the sudden dependency on technology, both for healthcare, telemedicine, and so on, and ordering in food, ordering other services online, has shone a light on a major technological gap among older adults that we knew existed, that many of us have worked to try and close, but has still become laid bare. So for my last slide, if you would, so what does this all mean? We're living in challenging times, but even in usual times, I would like to offer that no one is truly independent. We're all interdependent on each other, kind of a village. And, let's accept that and even celebrate it and take care of each other as we navigate COVID-19 and work towards healing ageism and other disparities and inequities that COVID-19 has laid bare. And hopefully together build a world together that we can all grow old in. My last slide is a reference slide, and I'm happy to answer any questions.
Thank you so much, Dr. Fain, for all joining us. If you have any questions, feel free to put them in the Q&A box below your screen. So the first question we have is, because the state has refused to release information on deaths at nursing homes, et cetera, are there other data sources that could be mined to get that information in another way?
It's not only nursing homes. That's a great question. And it's not only nursing homes that are refusing to release data. Many other hospital health systems are not releasing data based on privacy issues or however it's being discussed. It turns out that, and we talked, and I think that Greg might talk a little bit about this, but I'm happy to come back to it, is that it was just in mid-April that CMS announced a reporting system to track COVID-19 in nursing homes, and then to funnel that data to the CDC. And so that was just mid-April, and we're starting to see some of that data. And again, I welcome Greg to either add now or add later, but you're right, it's creating a problem. There's also a Delphi group that got together to answer the question as best as they could of what nursing homes should be doing in order to both protect the people and workers, the residents and workers, and to report. So there was just a Delphi report by AMDA, I think. But thank you for that.
Okay, and then we'll take one more question. This question will be more of a comment, or no, question. Can you discuss the implications regarding reinventing communicable diseases in nursing home? What needs to change?
Everything.
My apologies, preventing communicable diseases.
Sure, and I think thankfully that's become front and center, because nursing homes, I think people recognize now the risk not only to people in the nursing homes, but to the community from this. So I think that there's a disconnect between hospitals and nursing homes and all those pieces of our health system that were so interdependent have not really worked together. And I think that there are guidelines about communicable diseases within nursing homes that need to be guided, and resources need to be provided in order to make sure that those activities are done. But it can't be done in isolation. I think that's what we've all realized. It's really interdependent. I hope that answered your question. I'm happy later, if not, to revisit it.
Thank you. We'll do one more question and then we'll switch over to Greg.
Okay.
How much of the increased risk of older adults is due to nursing homes? How much is multiple chronic diseases? And how much is age itself? Or is it independent of other issues?
Boy, that's a great question. And I don't know who you are, but I would tell you that that's something you could research on. I think we're all scouring the material. I wrote, I think one of the references article that I wrote that from the early data coming out suggested that it was really a blend, that just being older, healthy older was a significant risk, added on all these other things. But we don't know the contribution of even something like frailty, which is known to be a strong contributor to poor outcomes in, let's say, surgery and so on. We don't even know how much that contributes. And that's different than age or comorbidities. So I'm just gonna sort of throw that out there. But thank you for that question.
Thank you, Dr. Fain. Dr. Meyer, feel free to take it on.
Thank you, Marcus. Good afternoon. And that was a wonderful presentation, Dr. Fain. And I will follow up on some of those points, but I'm going to shift the gears in the topic to really the point of care and meeting the needs of older adults. We all know, and many of us have been caregivers. I was cared for my parents up until 2 years ago when they died. But we know that there's challenges, and even in the best of times. But now, during this time, those challenges are magnified or multiplied. So it's a difficult time. And part of my conversation will talk about some of the positive and some of the issues that have a positive or a negative effect on meeting the needs, the care, emotional and psychosocial needs of older adults. And I provide this with some experience. As Marcus said, I've practiced hospice and palliative medicine for over 20 years and made many visits, I'm sure the same as Dr. Fain, in the home. And you see these barriers, you see the conditions, and some of them are great and everything can be provided, but many times they're not. And those are such disparities and barriers to care for older adults. And then I'm gonna have a couple of slides on my father-in-law who just turned 90 and kind of our personal experience dealing with him during this time and some of his medical issues. So next slide, please. I asked some students and colleagues that I knew had older adults, parents, grandparents. Many of the students have grandparents alive. And I asked them, what are you worried about now during the COVID-19 pandemic? And as you can see, they're variable. And many of you out there probably have the same worries. Loved one is frail and worried that he or she will get the virus. Talking about care facilities. A father or mother lives in a care facilities and is now currently understaffed. And as Dr. Fain said, staff are getting affected. And so many times these facilities are understaffed to start with. And they look for shortcuts. So it's not everyone, but again, all facilities, but now especially with staff and being these facilities being understaffed, people worry about their level and not getting enough food. Many times they're involved in that activity of daily living, but now have barriers to doing that. So they worry about that. Parents who live alone or a parent who lives alone. And this would compare to my father, who was a very stubborn man. And I don't know how many times he asked me for things or input. And I don't think he listened I know he didn't listen all the time. So you have people that don't listen and don't take the precautions, and that causes worry, especially ones that are very social and having visitors still, and you worry about them being exposed to the virus. Those who provide care personally for an adult or older adult, what if they get the virus? Then that changes the whole situation for being able to provide care because you're ill and may not have resources to hire someone temporarily or transfer them to him or her to a facility. And then the last one is kind of touches me because my mother died of dementia over a 5-year period. And there were times where she would be ill and I was able to call her and many times visit, but now family members cannot always make it to help out if something's going on. So those are just some of the worries that I came across. Next slide, please. We all fit somewhere in a spectrum or along a spectrum of health and wellness. And these are kind of the extremes, and there's a lot in between, but these normally will correlate where you are in these extremes and how much you need, how much care, support, etc. And that's for all of us. But as was mentioned earlier, as we get older, that dynamic changes and people depend on others more. Sometimes it's up and down, but it's a growing dependency. Even though they are independent, they have more needs. And that could be someone who has minimal needs to someone that has multiple needs and is very dependent on others for feeding or making meals or bathing themselves, the ability to dress themselves, those activities of daily living, bathing, etc. And so that's one of the factors. Our total overall health, again, could be very healthy as we're younger and we're healthy and don't have any issues, or maybe we have a few, and as we get older, we might start to develop some of those chronic illnesses such as congestive heart failure, lung disease, which have ups and downs. And during those periods where things get worse, those individuals need more care. And then on the end, it's the frail, very ill, poorly managed with few healthcare resources. Your ability to have support is very important to getting your needs met. Older adult may have a spouse, a partner, family, friends that can help. Then all the way to the other extreme, there is really no one. There's no family in town. A few friends, maybe from church or whatever, but they really don't have any or very few support in many ways, emotionally, not just for caregiving, but other things. Activity and emotional well-being are very important, especially in the older adult. Those who are active and engaged will again be normally healthier and have fewer needs. But then we go to that other end where someone's sedentary, maybe overweight, limited activity, and again, the needs and ability to provide care for that individual will be harder because there's more care that needs to be provided. Emotional well-being, if we're socially connected, great. But then if we're isolated and lonely, that's not great. And inactivity and being socially isolated are major risk factors for mortality in older adults. And so if those are present to a high degree, then that individual will have a much higher risk of morbidity and mortality. And those are both kind of on a par with smoking and obesity as far as risk factors. Next slide, please. Dr. Fain mentioned home can be many different places, and we've all seen it. I'm sure in the audience, the Zoomers out there have been in. I've been in all of these facilities, and they vary. Private residence can be great with lots of support, or private residence can be a lonely, empty place with one individual or a couple. One of those people, one of those older adults has medical issues. Living with family can be great, and many times the ability to meet those care needs of a parent or grandparent it's very helpful to have that family involvement and live with them. But then there's times where the family members work, they're busy, they're not available during the day. They have, or he has, or she has their own health issues. And so there's less support and ability to care for the older adult. Then on the far and unfortunate part of the spectrum, there's older adult that lives with a family member and there's really no engagement. There's no support. Yes, there's a roof over his or her head, but the ability or the involvement of that family member may be minimal. But again, at least has a resource there for some support. The group facilities, from a group home with maybe 8, 5, 6, 7 individuals living there, to more of the assisted living or the skilled nursing or the dementia units, those have an advantage or a plus that they have caregivers. Group home, usually the owner of the group home provides care. Maybe someone comes in and out, whereas the assisted living facilities, the nursing facilities have more people available. They have volunteers. They have nurses, a physician that comes by. So again, more on-site resources, but the quality and the staffing is very variable. And many of us have been in good group homes or good assisted living facilities and others that struggle. So just being in one of those facilities doesn't mean everything's going to be great as far as the care being provided. Next slide. We all have needs from the time we kind of leave the nest to the time that we die. I mean, and those needs we all have to address and meet. And normally over time, we do those on our own. We don't need support. We may not always do them well, missing appointments, not buying enough food, etc. But the normal situation for younger and middle age is those are done by the individual. But over time, that's where that dynamic or balance between an older adult still wanting to be involved and help himself, his spouse, whatever, it changes. And there becomes a time when more outside resources or support is needed. It's not, it switches overnight, it's a transition. But you know, those things such as buying the groceries, meals, getting them education, all the things that you can see tend to eventually, some of them, maybe sometimes all of at a time, all of them become the responsibility of someone else. I remember I mentioned pets up there. Oh my gosh, my parents' pets was almost number one to help provide care for them because they couldn't always do it. And again, the needs of people trying to stay physically active and exercise can change. My father-in-law, who lives in an independent facility, when this all happened, they closed the gym, they closed the activity center. He wasn't able to exercise as easily, and he didn't have those group events. And so that was a situation where that was done as a result of the virus. But we all want to still continue, no matter how old we are celebrating our birthdays, our anniversary, our holidays. Our daughter turned 30 a few months ago and had this big party planned, and that never happened. I think it ended up to be takeout and video conferencing, but we did whatever we could. And my last slide will show what we did for my father-in-law. So again, all of us have to have those needs met. Next slide, please. And this is to the people that may be in the audience, or I had some experience with this, but many of us have had a great deal of it. What if we're the caregiver and that grandparent, parent, even uncle, whatever, is dependent on our care for a lot? What happens if something happens to us, if we're a caregiver? And so this is kind of straightforward about what's important for someone that cares for an older adult. First and most importantly, they have to keep well. They have to keep themselves able to continue to provide the care and whatever other responsibilities, maybe jobs, etc. So they take all of the precautions that we're all starting to we've become very aware of. Whether they're in the home with their parent or grandparent, or at their own home, they have to practice social and physical distancing if they want to have the greatest chance of staying well. And sleep, eat well, take care of themselves, so that do whatever is necessary to provide care for that person. Also, we're aware of limiting unnecessary trips for ourselves and also for a loved one. But then also focusing not only, this is for all of us, keep connected. Keep your parent, grandparent connected, calls, video chats, letters, sending gifts, some things that many of us haven't done for a while. Can't remember the last time I wrote a letter, but I've written some recently. But then there are barriers to doing that. But if we have help and the desire, we can overcome those with technology or the video chats or we have internet issues or even having access. If we want to do calls to kids, grandkids as an older adult, we have to use the phone. I kept buying my father a bigger and better phone over the years, and I probably made it worse for him. But he got pretty good on a mobile phone. And so we'd use that. And now we're using that more with iPads and mobile phones to connect with all of our family and also my father-in-law. And then again, there's a piece of the technical skills. So keep connected and also keep our older adults engaged. The learning, the book clubs, anything you can think of, if you're involved, comes up. We do trivia night with my father-in-law. Started off a little rough. We saw a lot of Henry's name, a lot of Henry's wall and the ceiling and sometimes his feet until he got the positioning of the iPad right. But now we have a great time doing a trivia contest amongst the family. And then reconnecting with old friends and colleagues. I find myself doing that more because they come to my mind and I want to reach out. And I think that's good for all of us, but especially for older adults. Next slide, please. Mentioned this as far as regarding this social connection or well-being. This is extremely important. It's many times more difficult as we get older to continue to be out and about and not lonely. But that's where we all, with family members, even amongst ourselves, when we're all sitting at home for long times, we all feel isolated and sometimes lonely. But especially in older adults may have that as kind of a baseline. That's been their life, and now it's even worse. So it's important to really work collectively to limit that, because here's the reasons. Being isolated or lonely significantly increases an older adult's risk of mortality from all causes, and again, rival the risks of smoking, obesity, and physical inactivity. Loneliness has been associated with higher rates of clinically significant depression, anxiety, and suicidal ideation. And finally, substantial evidence links social isolation and loneliness with accelerated cognitive decline and an increased risk of dementia or incident dementia. So it's important, especially for older adults, that we focus on those areas. Next slide, please. As Dr. Fain mentioned, data is slowly coming out, and this was actually a recent article in New England Journal of Medicine about a facility in King County, which is a county in Seattle. I have a daughter that works up there, so very familiar with that. And here's what happened in this one facility. Over a 21-day period between February 28th and March 18th of this year, they had 167 confirmed cases of COVID-19, confirmed. And that, as we mentioned earlier, was spread out. The majority was the residents, 101 out of 167. Staff, that's a big number of staff to be down in a facility. It must have been a very large facility. Of course it was, because it had 101 residents. But then the visitors. And the visitors, the ages were obviously visitors, but the median age of the visitors was 44 years old, so younger people. And so this is what hit this one facility. Most of the cases among the residents included the respiratory component, but not all of them. As Dr. Fain said earlier, it's not always present or evident. In 7 residents, there were no symptoms or documented symptoms. And during that 21-day period, there were 34 deaths out of 101 residents, almost 34%. And that's one facility. And since that happened, or we're all aware of horror stories across the country, New York City, and it's a huge issue. And some of the challenges for any size facility is maintaining the staffing level. Again, maybe understaffed to start with, but now especially so with illness, not able to bring in temporary workers. How good were their infection control practices or policies and procedures? Because they're really important now. They're always important in a skilled facility, but they're really important now. Their access to PPE or protective equipment. What's the layout? 101 residents, they were either in double rooms or they had 100 rooms, which I doubt. And again, so just the ability of in an old facility or new facility that comes with some issues if they're older physical plant or physical building. So how well can they distance individuals? How well can they separate those who are ill but don't need to go into the hospital? And then the issue that's really a no-win situation for either side is restricting visitors. They're like volunteers. They're actively engaged in caring for their loved one. They help the facilities, but now with the regular rules and policies, they're restricted. And I'll mention my father-in-law, and he was restricted. And then lastly, facilities are dependent on outside vendors, food vendors, laundry, whatever it is, services, and then volunteers. So this is kind of the challenges in one incident or one example of what can happen in a skilled nursing facility. Next slide. Quickly, this is my father-in-law. Henry is his name. He lives in Madison, Wisconsin, where my wife and I grew up. He's 90 years old, or just turned 90. I mentioned earlier the independent assisted living facility. They stopped the meals, closed the gym, limited visitors. Fortunately, he had his private caregiver, one that helps him with the bills and things like that, and the other that helps him with shopping and other things. But fortunately has 3 loving, caring daughters who live in town who have children also. Devout Catholic, he attends church 6 days a week. And so he was going to church up until the time my daughter told him about cyber mass. And all of our worry went away because he wasn't going to mass, but he was getting mass and he was happy. So, and then medically, he's had some issues, and he was scheduled for a procedure to come out here in March to have done at Mayo Clinic in Arizona, but it was postponed because it was not a true emergency situation. He wasn't feeling great. He hadn't been for a while, but it was postponed. But then he worsened, and his family was able to get him up to Mayo Rochester, had the procedure done in early May, and is feeling great. So again, an issue there with getting some, not emergency care, but getting some care that made him feel much better. 2 more slides. Next slide, please. This is Henry III, MD, PhD. And my wife told me, no, he's not grandpa. He's Gigi Pa, whatever that means. So that's Gigi Pa, surrounded by grandchildren, feeling well. And again, that's support and connection that not everyone has. And the next slide will show how we celebrated his 90th birthday. We had all planned to go up there and join him, but that didn't happen. But the family and friends in town did this, and it's just a short video.
Dad, that's Peter and Vicky.
That's my sister doing the play-by-play there for Gigi.
They got in last night.
Standing out there, they both have their masks.
Oh, it's so sweet.
And not every adult has the family or the people to do this, but
We were gonna go.
Henry did, and it made a big difference. So,
He went the wrong way.
next slide, please. And that's my last one.
Awesome. Thank you so much, Greg. So let's see, what questions do we have? Wow, Greg, you've done such a great job. We don't have any questions.
Oh, I doubt that, but
let's see. So let's see. I'm sure people are typing some. Let's see. Well, while we're rating, if you could think of one thing that someone should take away from your presentation about supporting their elderly loved ones, what would you give them? What advice would you give them?
You just have to stop coming up with excuses why you're not going to do it. And when my parents were alive and healthy and had, there were times that I knew I should go out and visit, and I didn't. And then all of a sudden, within 10 days, that changed because they died within 10 days a couple of years ago. And so now when you're able to, and you have to share the load, you do it as a village, as Mindy said. It's a village, friends, church, whatever. It's so important.
A comment in the chat says, I love the parade for Gigi Pa Henry. Great job. Okay. Are there any policy changes you would recommend?
I bet Mindy has lots of them. We're seeing them evolve, and they're all, but again, it's not just having the policy, it's abiding by it and practicing it, no matter how healthy we feel or how stir crazy we become. I had the last slide, a little restaurant. I mean, who of us isn't dying to go out there? Slowly that's happening, but
Well,
any comments on that, Mindy? Or
I'm wondering, can you hear me? I got a little kicked out. Can you still hear me? Okay. That was a great talk, Ray. I'm still smiling from it. I think the policy that I would look for would be, as I said, we have these separate entities in health systems that are not connected, and in particular, and as your role at Hospice of the Valley, which is outstanding. Even things like funding for house call medicine, bringing teams into the home for people to care for them, to help them maintain their independence, is sorely lacking. And so, I think we're suffering that now because we have people who can't and shouldn't come in, let's say, to a clinic, or can and shouldn't come, where if we had a network, and I'm not just saying physician, all health professional, community health workers, paramedics. I mean, if we had that system that was appropriately funded, I don't think we would be as isolated as we are now. So I would urge looking towards an interconnected healthcare system that's home and community based.
It's interesting. I'm still actively in touch with Hospice of the Valley and the palliative care and other programs as I work on this ECHO program. And hospice, people on hospice, the numbers are going up. Mm-hmm. And it's pretty clear why, because those family members that used to be able to care for them, or patients are exposed to the virus, or the family is, there's a greater need. And I know with Hospice of the Valley, they have multiple hospice homes or inpatient units, and they've dedicated 2 for patients that have the COVID virus.
Yeah.
And done those precautions like any healthcare organization. But there's a lot of things that are stressed and stretched these days.
If I might add one other thing, one of the joys of taking care of older people is listening and hearing how they feel about death and dying, and that kind of growth and pattern that is really so comforting for really everybody. What I've noticed with COVID is that people who were, accepting of death are now very afraid of it, because they've been frightened by both the disease itself, and I'm sorry, I'm getting stuff. Frightened by the disease itself and the fear of dying alone. And so I think that's something to address with people who may not feel comfortable expressing that to families.
Yes, and I've had to see some of the pictures and read some of the stories that it is many times not a pleasant way to die. On a ventilator, prone, and it can happen quickly. So,
yeah.
Another question is, should we restrict what kinds of activities people can do based upon age, such as work activities or social activities?
Mindy, you're shaking your head, so go ahead.
No, go. I was just anticipating your answer. Sorry.
Well, it's the same as shaking your head. We're joined at the hip, kind of.
Except by 100 miles. But.
Yeah, right. Yeah. I mean, again, it's that inactivity, isolation that is very powerful in a bad way. Or a good way if you're active. But again, it's being smart about those things, going for a walk with a loved one. You just have to, some things you try to avoid, unnecessary trips out of the home or whatever, but not all of them. Fortunately, I have a sister who has special needs over in California, and she is scared to death. And she has not left her place there. She has some caregivers for 2.5 months. And I keep telling her and asking her, please get out and do some things. Walk around, but it's difficult. Everyone is dealing with this in very different ways.
Okay. And then our final question is, what are the key research needs that need to be explored regarding COVID-19 in older populations, or any COVID in older populations?
Well, a lot of it's being done. It's the vaccine, it's better testing, more access, not testing everyone. We know that that's not necessary. And then some of these potential cure, resmetivirus, I don't know if I said that right, but these things that are showing more promise, but not the Lysol or chloroquine or hydroxychloroquine or some of these things, and have it coordinated, not just everyone running off in their own direction versus collaborating with, internationally collaborating.
Right.
So.
Right. I would add with you that when we think about vaccines, which is the hope that we all have, that we recognize aging immune systems and do better than we've done with influenza. Yeah. And fund laboratories with the older person in mind, not make the same mistakes we've done in the past.
Well, thank you so much, Mindy and Greg, for joining us today. We really appreciate you taking time out of your busy schedule.
Thank you.
Thank you. It was great. Enjoyed it.
Thank you. And to all of you who are online, thank you for joining us as well. We encourage you to join us on Thursday, June 18th from 1 to 2 p.m., where we'll have part 2 of today's discussion, and we'll explore COVID-19 and its effects on various racial and ethnic minorities. Have a fantastic day and stay healthy.